nos estresa que la lente se pueda voltear.
Un paso importante, o sea, es una lente muy buena.
Y esto no va a pasar con la lente iClinic.
Y especialmente tamaños de 13. Nos van a hacer que tengamos un control.
El material de la lente Optiflex es un material muy resistente a la formación de microvacuolas.
And this may be the best hydrophobic in lenses I've never implanted.
Y con una rapidez de resultados bastante impresionante.
Es una de las escasísimas lentes con las que me siento cómodo.
Confirman una respuesta excelente a todas las distancias.
De una manera mucho más agradable, mucho más amistosa y con menos posibilidad de que podamos encontrar algún volteo a la hora de poner la lente en cámara anterior.
O sea, quirúrgicamente se comporta de forma excelente y el aspecto de la lente es excelente.
Los estudios de laboratorio sugieren una gran seguridad.
Muy buenas, de nuevo desde el auditorio de Visumiranza en Alicante, en un día radiante de sol y de ciencia y de conocimientos, gracias a los ponentes que nos acompañan en este día para ARI 2023. Esta es una sesión del Área 4 de Cirugía Refractiva, en la cual me acompaña el profesor Miguel Maldonado, que está conmigo en este momento, y que hemos construido juntos como una tertulia basada en la evidencia. Tan solo participan en ella compañeros que tienen al menos 5 papers publicados en revistas impactadas durante los últimos 5 años. Por tanto, es un panel de expertos altamente cualificado. Y lo hemos desarrollado como un panel de expertos en tertulia, porque cada uno de ellos va a mostrar un caso clínico, comentándolo con ello cuál es su actitud ante la solución de la presbicia o su compensación por distintos métodos disponibles, para finalizar con una discusión abierta de cuál es la orientación que debemos dar a los presbitas incipientes, intermedios, avanzados o en casos especiales como los amétropes. Así que quiero dar las gracias a Felipe Bejarano, Ramón Ruiz Mesa, Julio Ortega, Federico Alonso, Dan Reinstein y el profesor Wolfson, que va a abrir esta sesión con una keynote precisamente sobre este tema. ¿Qué hay en este momento disponible para el tratamiento de la presbicia? El profesor Wolfson tiene la palabra. Welcome to ARI 2023, and this is your time. Thank you.
My name is Professor James Wolfson from the University of Aston in Birmingham in the UK. And this talk is entitled, What is Available Today for the Correction of Presbyopia? My disclosures are on this slide, and I work with a range of companies from spectacles all the way through to intraocular lenses. So first of all, we need to define what presbyopia is. It's derived from the ancient Greek, translated into Latin as an old man and to see like. When we think about how we define it, it's not really about accommodation per se, but of course that's what causes it, the reduction in our eye focus with age. But if we think about being an old man and to see like, it's about the functional side. So presbyopia has been defined as occurring when the physiologically normal age-related reduction in the eye's focusing range reaches that point when, optimally corrected for distance vision, the clarity of vision at near is insufficient to satisfy an individual's requirement. So it's really important that it's focused around the patient. It's important to declare our disclosures, and of course we all have a vested interest in presbyopia until we find a solution to aging. So here's my son when he was much younger. Still, his near focus was declining even at that young age. By the time he was a teenager, it was declining slightly more, but nothing that he could visibly see. When you get to the age that I started at Aston University, on that slope, but again, still not many problems until now, and definitely into that presbyopic age. And then finally, like my father, no real eye focus at all. What are the options for correcting presbyopia? Of course, we have our spectacle options, such as bifocals or multifocals. We have our intraocular lenses with multiple different zones or segments or diffractive optics. We have then attempts at actually restoring accommodation with lenses. We have our laser refractive surgery as well. In terms of the principles then, so the eye can move to look through different parts of the lens. Of course, that happens with spectacles. More often we are splitting light, such as with contact lenses or intraocular lenses, or in increasing the depth of focus, which we can do pharmaceutically, or with lens aperture or optics. And ciliary-driven, muscle-driven accommodation is, of course, our aim, to be like the younger eye, and we have lens softening options potentially as well in the future. So in terms of our spectacle options, this is really an area where there's very little research. These lenses, of course, are very common and the mainstay of what is prescribed. Nowadays, much more aggressive lenses or varifocals, so optics that change gradually through the lens, but you're going to get peripheral distortions in the periphery. Not so much your bifocals where you have a certain segment, although those do exist. If we move on to current presbyopic contact lenses, this is a survey a little while ago now looking at patients, particularly over the age of 45 and what they were prescribed. And you can see that the number of people in contact lenses actually drops off even before that age. And if we break that down, actually more than half of them are just wearing a single vision distance correction, so they would need some kind of spectacle correction over the top. And some of those are in multifocals, some of those in monovision. And that really does change depending on what country they're in the world. So some countries are very good at fitting multifocals to those who need them, other countries much less so. Now, I do have updated data from the developer of that questionnaire, a friend of mine, Professor Phil Morgan, and this shows the data right up to 2020. They do this survey every year, and you can see generally people who are over the age of 45 are now being put into at least multifocal or monofocal contact lenses if they choose to stay in that modality. Monovision, of course, is the other option that we can do with contact lenses, and there have been various studies showing how successful that can be, and it can be relatively successful, particularly for lower ad powers. Once you get to higher ad powers, the individual loses their stereopsis, and it can cause symptoms such as headaches at the end of the day. And the paper there, a little bit old again, by Riley, showed that if you try this first with contact lenses and take successful contact lens monofocal wearers and put them into intraocular lenses in the same modality, then you get a very high success rate. And alternatives are things like modified monovision, where you might put a multifocal in one eye and a distance lens in the other eye. So there are opportunities to mix and match to get the best result for an individual patient. In terms of multifocal contact lenses, there are three different options. Those are lenses that translate, so they move. These are typically your rigid lenses, because soft lenses don't move very much on the eye, and you have to have quite a taut lower eyelid and make adjustments to the lens so it actually rests on that and it's pushed up when you look down and in, up and out, so the optic now changes from distance to near. The majority of our lenses are more of the concentric design, so these have rings of distance and near. They can vary in size to be a bit more pupil intelligent to try and get the right balance between distance and near, depending on what distance you're focused away at. And then we have aspheric designs, either center distance or center near, again to get that change in power and extended depth of focus delivered to the individual. And contact lenses can be in many different modalities, so daily disposables, fortnightly or monthly lenses, different materials, and as we said already, they perform differently. And also we can have now multifocal torics, so we can correct astigmatism at the same as alleviating presbyopia. And if we look at the profile of those lenses, you can see here those sort of more aspheric profiles or ring profiles that have been developed on the lens, and they can even change their profile depending on power linked to what sort of pupil size you get for each of those modalities. There's a lot of research in this area. It's become more detailed over the years. So you can see a lot of testing, not just of acuities, but focus curves, what happens in different lighting conditions and glare, and also looking at the subjective response as well. So these are the sort of main studies that have been conducted over a 20-year period. In terms of multifocal intraocular lenses, of course, we have a range of those, refractive, diffractive, aspheric, trifocal, segmented, and mix and match type modalities. So concentric IOLs were more the early designs of intraocular lenses. Most of them have moved on since then to more diffractive, combination refractive and aspheric type optics. And of course, now we have our trifocal designs. So those small echolets on the lens surface in a sort of tooth saw type configuration, but by changing the height of those echolets in an alternating pattern, you can overlap two profiles with their second principal point either at intermediate or near, and so they combine. So the second principal point will then contribute to the near as well. So you save some of the energy loss that you get with a diffractive optic, while at the same time boosting the intermediate vision. Segmented lenses have also been developed. This is unlike a bifocal spectacle lens in terms of you're not looking through a different portion. The light from both the distance element and the near element are projected onto the retina at the same time. But there have been studies showing that there are some benefits, particularly in terms of the glare profile, that's not spread over the whole lens. And then we have our extended depth of focus technology, diffractive, soft materials to try and allow some flexibility, and small aperture type lenses. Accommodating lenses have been developed over the years, and there are a range of those, and there's this very nice review now looking at how effective they are compared to some of our multifocal designs that you can see on this slide. We had our initial single optics with our flexible haptic, the idea to move forward, but you didn't get much accommodation out of those. And unfortunately, with fibrosis, most of that effect, even though small, was lost. Similar with our dual accommodating lenses. So again, slightly more possibility because now you've got a telescope type design. But again, that effect was lost with time. And shape-changing IOLs are the main ones that are being developed now. You can get much larger changes in optics. However, there are not many academic papers on those as yet. Future accommodating designs, again, lots of different designs have been worked on over the years and are still being worked on, particularly with fluid actuators or base units and attachments to those. Light adjustable lenses can be created in a multifocal format and flattened to a spherical format if they don't work. And a lot of surgeons use more mix and match type technologies. Laser refractive surgery, of course, is an option, as are corneal inlays. And then people have tried things like scleral expansion and buckling surgery, scleral expansion with very limited success. There's some early papers on buckling suggesting that this can be more effective. Pharmaceuticals is the big new area of interest, although some of these have failed in phase trials. But we do have myotics on the market now, but there are some studies suggesting that retinal detachments can occur and that the benefit is moderate with approved clinical trials of 1.25% PARPin, finding between 12 and 22% of patients reach the criterion for near visual acuity compared to a placebo. And then there are other more far-reaching treatments that have been suggested in the literature, such as electrostimulation, to actually improve the thickening of the ciliary muscle, although that hasn't been translated into a benefit in near vision. So, of course, there are some considerations to have with any patient. If it's a lens that goes on the eye, then it's things like centration, pupil size affects pretty much all of our designs, and also the aging optics and the combination of the lens with that optics and keeping the eye comfortable and with good physiology. And just to end, to mention that the BCLA are running a consensus group on presbyopia, looking at all of the literature and bringing us up to date with a special issue that will come out in 2024, and you can see each of the topics there. Thank you very much for your attention.
Thank you very much, James. Excellent talk. And we are put into scope what is presbyopia today. We're going to take now Professor Maldonado, who is going to conduct the debate initially. Así que tenemos ahora el gusto de tener a nuestro compañero profesor Maldonado, que va a iniciar los casos clínicos y el debate que va a seguir a ellos. Tiene la palabra.
Buenas tardes. Muchas gracias por contar conmigo, profesor Alío, y todo el equipo que tenemos aquí en Miranza. Me gustaría poner de relieve que efectivamente en todo el mundo hay cerca de 2 billones de pacientes que son presbitas. Por lo tanto, la demanda de corrección de la presbicia o compensación en alguna de sus maneras es creciente, y este es un aspecto fundamental en el que la cirugía refractiva ha crecido. Disponemos en el panel de grandes expertos que tienen una experiencia que van a compartir de distintos casos, y a mí me gustaría que, aparte de darles paso a ellos, pudiéramos hablar de cuáles son los criterios en los que basamos fundamentalmente nuestra evidencia científica a la hora de aconsejar un tipo u otro de corrección dependiendo del tipo de paciente. En primer lugar, va a ser el doctor Federico Alonso el que nos va a presentar su caso. Adelante, por favor.
First of all, I would like to thank Alicante Refractiva International and the moderators for their invitation. I have worked with several platforms. Also, the platform I have the most experience is with the CalSaid platform, Presbicia. It is important to determine the prognosis of the surgery. For that, we have to take into account several parameters. It is important to understand how binocular vision works. This will determine whether some patient will be able to have good, far, medium, and near vision, or only distant and medium distance. With these patterns, we can determine the prognosis of our surgery. As is for low and medium myopia, as treatment optimizes in the dominant and presbyopia in the non-dominant. For high myopia, focus lens. In hemetropia, in patients who do not wear glasses, it is especially important to confirm the refraction with the cycloplegic. As treatment, dominant eyes. We do not treat, and in the non-dominant eye, presbyopia treatment with hemetropia. For low hyperopia, with the use of glasses for distance, we recommended as treatment the hyperopic presbyopia in dominant and non-dominant. In medium hypermetropia, we do not need a contact lens test. The residual ametropia for near vision does need to be so high as a treatment hyperopic presbyopia in dominant and non-dominant. The residual here are usually smaller than the low hypermetropia for the same age. Nomogram of non-dominant eye. We will need more myopic defocus in the non-dominant eye according to the functional age of the patient, with high near vision requirement, a small chamber, high densitometry, when we are going to make small changes in aberration, when the keratometry is low and when the ametropy is low. Clinical case, patient of 48 years old, operated 6 years ago for hyperopia. Bilateral visual acuity far 1.0. Initial presbyopia with visual acuity near 0.6. Right dominance. In the presbyopia program, we do not mark the tolerant test of 1.5 diopters, and we do not use an isometropy higher than 1.25 diopters in any case. Although we use the defocus according to the key point of our nomogram. In surgical programming, we wore an internal side cut of 8.5 millimeters when the previous one was 9 millimeters, referring to the initial 6 years ago, and 10 microns deeper. The previous one was 100 microns. With these techniques, we work the initial presbyopia in patients previously operated, making a new cycad that decreases the risk of epithelium in interface and the treatment of pericarditis, which in peropia has worse outcome and stability. Thank you very much for your attention.
Muchas gracias, doctor Alonso. La verdad es que la presentación ha sido excelente y ahora me gustaría dar paso al doctor Ramón Ruiz Mesa.
Hola, buenas tardes de nuevo. Me he presentado un caso clínico, nada especial, solamente aprovechando el nivel de los panelistas, la opinión y orientación que nos pueden dar sobre ella. Se trata de un paciente, y esto nos gustaría antes unos puntos de entrada para dejar claro al menos nuestra postura a la hora de abordar la cirugía refractiva del cristalino, es que no somos partidarios de entrar en cambios de lente sobre un paciente métrope. Siempre resaltamos que va a perder calidad, sensibilidad al contraste lejos, que a lo mejor no le compensa por lo que vaya a ganar cerca. Cuando estamos hablando de paciente hipermétrope, esperamos que este paciente hipermétrope presente ya presbicia, y con la presbicia y el defecto de lejos sí abogamos por una cirugía de cristalino transparente o bien de catarata con mira a poner una lente trifocal. En pacientes miópicos, para disminuir el riesgo de desprendimiento de retina, abogamos por más o menos, ya tengo un desprendimiento de vínteo claro que suele pasar aproximadamente por encima de 55 años. Y por supuesto tendremos que distinguir entre, cuando estamos hablando de pacientes que desean quitarse la gafa sin tener ningún problema en el cristalino, o bien si ya hay una disfunción, ya aparece un tema de presbicia, cambio de aberrometría, o bien que hay una catarata. En este caso, acude a consulta a un paciente de 57 años de edad con un antecedente de cirugía miópica láser y la juventud exitosa, con lo cual el paciente está acostumbrado a estar sin gafas y acude a nosotros porque en el ojo izquierdo está notando una alteración en su visión. En el examen visual vemos que la agudeza visual del ojo derecho es impecable, 10 décimos, pero en el ojo izquierdo son 2 décimos, lo que no encontramos que mejora solamente con una refracción miópica a 4 décimos. En la lámpara de hendidura destaca una catarata nuclear en el ojo izquierdo y el resto de exámenes que se le hace al ojo, mácula, la OCT de mácula, superficie ocular, montaje endotelial, todas las demás pruebas son absolutamente normales. Después de analizar el caso, repasar la distribución de potencia corneal, la aberración esférica corneal, la aberración de alto orden, pues el paciente con una ablación centrada muy buena es óptimo para poder ser implantada una lente trifocal, dado que el deseo del paciente, como ya hemos dicho, era seguir viendo bien en todas las distancias. Decidimos operar con una lente trifocal y aquí viene la disquisición, por si puede surgir algún tipo de comentario al respecto, ¿qué es lo que haríamos? Si en el otro ojo, el ojo derecho, mantiene una visión de 100%, por supuesto, con la adición de cerca por la edad, ¿cómo procederíamos según vuestro criterio? Esperar y a ver cómo se adapta después de la cirugía del ojo izquierdo operado, no hacer nada y continuar con el soporte para cuando vaya a ver al cerca el ojo que no se ha operado, o bien directamente operar cristalino transparente con una implantación similar de lente trifocal en el otro ojo. Pues nada, eso es lo que quería comentar. Muchas gracias.
Muchas gracias por este tan interesante caso que ha presentado el doctor Ruiz Mesa. A continuación, el doctor Julio Ortega Usubiaga nos va a presentar su caso.
Buenas tardes a todos. Me pide el profesor Alio que traiga un caso clínico de un paciente operado de una presbicia ya avanzada y vamos a presentar un caso clínico de lente trifocal translásico hipermetrópico. No es algo que hagamos todos los días, pero sí me encuentro casos como este 1 o 2 veces al mes. Se trata de un paciente varón que operé hace ya 15 años. El paciente tenía 58 años, tenía un astigmatismo hipermetrópico compuesto, como ven, en contra de la regla. Y a los 3 meses el resultado fue estupendo, una agudeza visual sin corregir de unidad. Sí que es verdad que en el ojo izquierdo había quedado algo hipermétrope, pero bueno, el paciente tenía buena visión y estaba contento. Nos encontramos, pues lógicamente, en la típica córnea encurvada de los LASIK hipermetrópicos. En febrero de este año, el paciente, ya con 72 años, acude a mi consulta porque ha disminuido su visión y efectivamente tenemos unas agudezas visuales sin corregir lejanas de 0,2, 0,7. El paciente ha miopizado por culpa de una catarata de índice. Y bueno, y aquí tenemos las topografías. Tenemos la típica topografía tras LASIK hipermetrópico, en este caso con un astigmatismo corneal de 1,6 dioptrías, unas aberraciones corneales totales de 0,36 que no son excesivamente altas para un LASIK hipermetrópico, pero sí que tenemos un Z40 pues muy bajo, casi 0 micras. De cerca el paciente tampoco veía demasiado bien, a pesar de esa miopía teníamos un Jäger 5 en el ojo derecho y un Jäger 11 en el ojo izquierdo sin corrección. Esa es la topografía del ojo izquierdo, también la típica ablación hipermetrópica. En este caso, las aberraciones corneales totales son bastante más elevadas, 0,5 micras, que sería un poco lo máximo que yo me plantearía para introducir una trifocal, pero tenemos una Z40 que tampoco es muy baja, 0,25 micras. En este caso he decidido introducir una lente Ray 1 trifocal porque tiene una aberración esférica nula. Es decir, yo lo que no quiero es bajar más aún la aberración esférica que ya tiene el paciente con LASIK hipermetrópico. Como no tengo lentes intraoculares trifocales con aberración esférica positiva, pues lo que hago es introducir una con aberración esférica neutra. Y a los 3 meses de la cirugía bilateral, pues me encuentro unas agudezas visuales sin corrección muy buenas, de 0,9 con cada ojo, y una refracción residual pues muy pequeña. En cerca estamos en Jäger 3 y en intermedio Jäger 5 aproximadamente. Casos como este me animo a introducir una trifocal tras LASIK, pues gracias a la evidencia científica que tenemos de papers publicados recientemente. Y ese es el resumen de lo que nosotros hacemos tras un LASIK hipermetrópico. Primero miramos la RMS, aberraciones de alto orden, pues que no pasen de 0,3, 0,5, que tengamos una buena topografía, una buena agudeza visual lejana corregida. Y entonces ahí podemos plantear una trifocal. ¿Cuándo? Pues hombre, cuando tenemos ablaciones hipermetrópicas bajas o medias, con una Z40 muy poco positiva o muy poco negativa. Es decir, en el caso que es poco positiva, pues podemos todavía plantear una trifocal con baja aberración esférica negativa, quizás no FAIM, no ZAIS, pero enseguida, en cuanto vemos que la Z40 baja mucho o se pone negativa, directamente vamos a una Ray 1, que es como el caso que acabo de presentar hoy. Si la ablación fuera muy alta, la Z40 es claramente muy negativa, vamos a monofocal, o si la mala topografía o la mala agudeza visual corregida o las RMS hacen que pensemos que es mejor una lente monofocal. Una vez más, gracias al profesor Alio por su invitación al ARI 2023.
Muchas gracias al doctor Ortega Usubiega por su presentación, en la que efectivamente caracteriza muy bien el caso en el sentido de que si una lente intraocular, en este caso multifocal, nos va a proporcionar la multifocalidad gracias a una óptica, por ejemplo, difractiva, lo que tenemos que intentar es que por lo demás el resto de la óptica no vaya a favor de incrementar la aberración esférica, en este caso negativa, que tiene un caso de LASIK hipermetrópico previo. Si estuviéramos, no obstante, ante el caso contrario, es decir, de un LASIK miópico, buscaríamos efectivamente una lente intraocular cuya base de óptica fuera asférica, proporcionando aberración esférica negativa que compensara así la positiva de la córnea. Ese punto es muy interesante y creo que es una perla que deberíamos todos tener en cuenta a la hora de elegir la lente intraocular multifocal que mejor se adapte a la córnea de nuestro paciente. A continuación vamos a dar paso al caso que va a presentar Felipe Bejarano.
Hola, buenas tardes. Mi nombre es el doctor Luis Felipe Bejarano, soy de Popayán, Colombia. Primero que todo, quiero agradecerle al doctor Jorge Alio por la invitación a participar en la actualización del tratamiento de la presbicia, una tertulia basada en la evidencia dentro del Congreso ARI 2023. Voy a hablarles un poco sobre el manejo farmacológico de la presbicia con el producto que yo desarrollé y he llamado FOB Tears. El producto tiene un parasimpático mimético y lo tengo en 3 diferentes concentraciones, la estándar, la plus y la super plus, para ser usadas dependiendo del nivel de presbicia. Tiene un alfa-1 agonista selectivo, un anticolinérgico, un antiinflamatorio no esteroideo y un vehículo. El producto mejora 2 a 3 líneas de visión cercana sin corrección con la primera gota. ¿Cómo uso las FOB Tears? La estándar es para presbitas incipientes hemétropes, o sea, de menos 0,50 más 0,75, menores de 47 años, con visión próxima de 20-40 o mejor. Las plus para presbitas incipientes levemente hipermétropes, ya entre más 1 y más 1,50, o para todos los presbitas moderados, entre menos 0,50 a más 1,50, entre 48 y 52 años, o también para cualquier paciente que esté usando la estándar y que sienta que el efecto no es suficiente y que le gustaría sentir más efecto, puede subirse a la plus. La Super Plus es para presbitas incipientes o moderados ya hipermétropes, o sea, igual o mayor a más 1,75, o que sean malos respondedores, así sean menores de 47 años, muy jóvenes. Para todos los presbitas entre menos 0,50 y más 1,75, mayores de 53 años, y para cualquier paciente que esté usando las plus y que sienta que el efecto no es suficiente y que le gustaría sentir un poco más efecto. El caso clínico que les quiero mostrar es una pareja de esposos que asistieron a consulta el 5 de agosto del 19 por presbicia. Al examen, ella con 43 años, o sea, una presbicia incipiente, él con 56 años, una presbicia avanzada por edad. Ella con su visión lejana sin corrección de 20-20 en cada ojo, hemétrope, y cercana de 20-60 en cada ojo, que sería una presbicia moderada. Él con ligera miopía en su ojo derecho y con visiones de 20-50 y 20-30, respectivamente para lejos sin corrección. El ojo izquierdo es levemente hipermétrope y cercanas de 20-30, que sería una presbicia incipiente, y 20-60, que sería una moderada, respectivamente. En ese entonces inicié las FOB Tears en concentración estándar, que es la de más baja concentración para ella, y las plus en él, que para ese entonces eran las de mayor concentración, no existían las Super Plus. Y mejoraron a las 2 horas. Ella seguía con su 20-20 de lejos y llegó a 20-20 de cerca sin corrección en cada ojo. Él mejoró de lejos a 20-40 una línea en su ojo derecho y 20-20 en su ojo izquierdo, que era levemente hipermétrope. Se sintió muy bien, aunque de cerca no sintió tanta mejoría. Mantuvo su 20-30 en el derecho y mejoró una línea en el ojo izquierdo. Ella feliz con el resultado, él quiso iniciar a ver cómo se sentía en la vida real y se le explicó que si no fuese lo suficiente se le propuso un reemplazo personalizado de cristalino. En el control telefónico de la semana comenta la esposa que los dos están felices, que ella las usa una sola vez al día, que el esposo 2 veces, y comenta que él no volvió a utilizar sus gafas. Ella siente ocasionalmente ardor, por lo que se le ordena lubricantes. En el control del mes, los dos muy contentos, con los lubricantes le pasó el ardor a ella y dice usarlas 1 o 2 veces al día según necesidad y el esposo 2 o 3 veces. Que si siente la necesidad de gafas, él aumenta entonces la dosis un poco más. Dice que aunque se le explicó que la mejoría podría no ser la mejor en él, se siente perfecto y que no requiere ni irse a la cirugía y que para ver mejor sí nota que requiere buena iluminación. Finalmente, los pacientes han seguido usando el producto por todo este tiempo, ya llevan 19 frascos cada uno y su renovación inicialmente era cada 2 meses y luego se tornó a cada 3 meses, lo que podría significar que requieren un poco menos de dosis que inicialmente, o sea que el cuerpo ciliar con el tiempo y con el uso crónico o prolongado puede mejorar su acomodación. Algo de notar es que ambos más o menos a los 2 años se les pudo dar la gota de siguiente mayor concentración, o sea ella pasó a la plus y él pasó a la Super Plus con una aún mejor sensación visual en ambos y su último pedido fue en julio de este año, o sea, ella ya con 47 años, que sería una presbicia moderada, y él con 60 años, que continúa con su presbicia avanzada. Muchísimas gracias.
Muchas gracias, doctor Bejarano. We have the pleasure to have Dan Reinstein with us. He's in contact with us from Australia, and I would like to ask him. He has had a very wide experience on presbyopia correction with excimer laser and has been pioneering many techniques successfully. What is your current evidence-based criteria for indicating one or another technique for presbyopia correction, Dan?
Well, for me, it is not age, which is what most people seem to be going by. I think that's ageist. For me, it is the health of the eye, the contrast sensitivity, the objective measures of visual quality, contrast sensitivity, ocular scatter index, DLS from the Tracy. You could look at the HDA from Portugal. You can look at the C-Quant. There are lots of measures of objective measures of visual quality. And if the patient has no cataract, the best spectacle corrected vision is maintained. And there are objective measures of clear crystalline lens. We do not replace the lens. And that is an indication for treating the cornea. And you fantastically, I was very impressed with your comment about selection of IOLs post-corneal surgery. After someone, if someone, not everyone develops cataract before they die, but if they develop a cataract, then we choose a lens that is monofocal, not a multifocal like I heard a few minutes ago. And we get full independence from glasses because the spherical aberration is on the cornea. The spherical aberration is set on the visual axis, which cannot be achieved with aspheric lenses that have tilt and decentration, which can give visual quality compromise. And it's a much better solution for the patient.
Very good, Dan.
De hecho, ¿por qué estoy hablando inglés?
Well, we have Dr. Wolferson. Jens is with us, and probably we can talk in English for a while, you know. But we have a good display here about what is available. You know, we have drops. Felipe is using drops even in advanced presbyopia. We have corneal surgery. Federico has shown his experience, and you have long experience as well. And we have laser replacement, which is on fashion now. But it's on fashion on ages that probably are not adequate. So my question to you now, for early presbyopia, defined as those that have plus 1.5, okay? And at that moment, they need glasses, obviously. What is your first choice? Number one choice. Dan, for you?
Presbyond. If they are candidates for LASIK, Presbyond. Why? Because it's a semi-permanent solution. And if they tolerate the full ad, then as long as nothing changes, they're not going to need glasses for 5, 10, 15 years. And if they do, then they just come for a small adjustment, which is very easy to do, and they're out of glasses again. And they've taken a low risk with high accuracy, and their visual quality is not compromised.
Very good. And Federico, what is your option for early presbyopes? Defined as those that need up to plus 1.5.
And I think for me, for people with older after 55 years, I prefer the Presbyond. Only with and the fact of the contrast visual vision, I prefer the Presbyond. For me, the Presbyond is the best option.
Okay, and Julio, for you, because it seems that you are much more for lenses, but what is your number one option for early presbyopes?
Well, it would depend on whether it's myope or hyperope, right? If the patient is myope for an early presbyope, I would choose LASIK or PRK with monovision. I don't have experience with those Presby LASIK platforms, and I'm very confident with the classic monovision, which is with a non-dominant eye for 1.25 or 1.50. Then if the patient is hyperope, or even if it's emmetropic, I would choose refractive lens exchange for sure. That's what we have proven in our papers. I know it's maybe controversial, and maybe some doctors are not, well, they don't share my opinion, but it's what we do, and we are very confident with that. We don't find any risk with any high probes.
Oh, wait a minute. You say no risk, but I mean, there's the published evidence on intraocular surgery in humans in their 40s is clear. The risk of lens surgery goes down exponentially the older the patient. So I'm surprised to hear you say that, actually.
I didn't say operating a patient with 40 years old. Then I want to talk about someone who is presbyo with plus 150 in cornea and high probe. Maybe the patient is 1.50 for far, and it's plus 3 for near. That patient for me is a clear lens extraction for sure. It's not a LASIK, and even it's not. Listen. It's not a Presbicia platform. I know you like that. It's okay. So I mean,
it's not. No, Julio. It's not about liking it, okay, Julio. This is a scientific meeting. We're not in a beer garden. We're not in a beer garden having beers.
For sure.
This is a scientific meeting. And Julio, let me ask you one question. 51-year-old plus 150. Risk of clear lens exchange in both eyes. I don't know if you're going to use a multifocal, probably.
Yeah, trifocal.
Compared to the published risk on the 9 publications that are already published in the medical literature about accuracy, contrast, and safety for Presbyon, please tell me that you don't think that the safety...
I would ask you on the contrary, please, Dan. Tell me how much literature do you know about patients with 60 years old, 70 years old, who previously underwent Presbyon in the past, and now they want to get rid of the glasses. What would you do? Maybe a trifocal?
Well, Julio,
what about the cornea in those patients?
This is a beautiful...
I wouldn't like to have a Presbyon cornea.
Julio, you really don't understand this. Okay. Because if you understood it clearly, you would understand that when you treat a plus 150 or a plus 3 in a cornea on the visual axis, because there's angle kappa in these hyperopes. And then when they're 70 years old, you do a cataract surgery with a monofocal IOL. You get near total independence from spectacles, thanks to the depth of field in the cornea. And there is much lower risk of doing the surgery when the vitreous is detached and the patient continues to see independent of spectacles with high quality vision and a low chance of PCO. This is where the misunderstanding happens. You're coming from a sort of folkloric background where it's dangerous to do cataract surgery after LASIK. I think doing cataract surgery after LASIK is fantastic because you use the Barrett-True-K formula, you get incredible accuracy, and you can use high-quality monofocal IOLs. You don't have to resort to these crazy diffractive lenses.
Okay, I mean, I'm not folkloric, although I'm Spanish, but I'm Basque. So we in north part of Spain, we're not so folkloric. But I mean, if we talk about science, which is what you're talking about, you haven't answered to my question. What about scientific evidence for patients who underwent Presbyon in the past, and now they want to seek, they want to get rid of glasses and they are 70 years old? You know what? We don't have evidence. You know why? Because this is a new surgery. Now, this is number one. Number two, I will send to your email, if you want, my evidence paper published with trifocals after LASIK. This is not mentioned. I'm not aware. I'm not afraid. I'm not afraid about LASIK. You know, I perform trifocal after LASIK every week, several patients a week. So I'm not afraid. So it's not a matter of folkloric. It's not a matter of frightened. It's a matter of science. So now, I don't want a Presbyon cornea. Do you want it? I don't want. I prefer. If it's mentioned,
obviously, you're obviously not familiar with the Presbyon.
Dan, if
you're not familiar.
That's the first sentence I said. I don't have experience with Presbyon, but I have a lot of experience.
Well, then don't say you don't want it if you're not familiar with it.
I know.
Whereas,
but I don't want.
I have complete command of the literature on the accuracy of trifocal lenses on virgin corneas, and 50% of the eyes, maximum 60, are 20/20. Whereas when you do a monofocal after Presbyon, I agree with you 100%. We haven't published this yet. I agree 100%.
But I have published. But listen.
No. Excuse me.
I have published about trifocal lensing.
Okay.
Yes, I have.
What percentage of eyes are 20/20 in your publication?
Okay, I think that we have to moderate a bit. Just wait. I think that we have somebody, yes, James Wolfson is an expert, on presbyopia, and probably he can give to us an opinion. James, can you tell us, based on evidence, which is the risk-benefit of corneal procedure versus intraocular procedures? Can you say that?
Sorry, were you talking to me, Jose?
Yeah, can you tell us, based on evidence, the risk-benefit of corneal presbyopia surgery versus intraocular surgery with multifocal or EDOF lenses, risk-benefit, the risk of the cornea versus the risk of intraocular surgery in these early presbyopages? What is your opinion based on evidence?
I think that there's limited evidence at the current time across the platforms. So there's individual evidence on some of the platforms, but some of them are much newer. And again, actually, your example of a 51-year-old plus 150 is exactly me. And would I consider surgery at all? No. So again, it depends very much on the individual person in your chair and making a decision about what's right for them. And that may well be surgery.
That's not what you were asked, right? You were asked about the difference in risk between you, as you said, having an intraocular surgery and LASIK.
Yes. And
that's the question.
Yes. And to me, there's not enough evidence on all
there
of
is not enough evidence.
Procedures. There's good evidence on some procedures.
Come on. You need to review the evidence on intraocular surgery and eyes with attached vitreous.
Intraocular. Any evidence is not about Presbyon. It's LASIK and intraocular surgery. There's enough about risk. And I'm agree with Dan. I'm not doing Presbyon, but I have another kind of presbyopia treatment. I remember with, I don't know how many years with Dan, we present many papers together in the ASCRS. I present my double ablation for presbyopia, and Dan present the Presbyon at that time. At that time, the name is not Presbyon. And always we try to do the same. Try to improve the dominant with aberrations and as the non-dominant for near, but another kind of aberrations. So binocular is an additional vision to help together. So the contrast sensitivity doesn't decrease. After 3 months, I took the measurements in my technique. After 3 months, the contrast sensitivity is the same. So for me, I'm agree. The risk in a superficial surgery is 100 times less than a 100%. And believe me, I consider myself a very good phaco surgeon. And even I made 1 millimeter surgery when we made Faconit with Agarwal and with Jorge. And I really believe that intraocular surgery always has more risk. Of course, there's some cases that need intraocular. There are some cases that are superficial. And for me, when you have the possibility of use topical or pharmacological, also there's patients for pharmacological. Not only one treatment is for all. And also you have to select which patient is better to use topical. If it doesn't work, for me, in my case, 51-year-old patient plus 150, I try even the Super Plus, maybe in that patient, if he doesn't be satisfied, and I have patients like that, I made my presbyopia treatment with LASIK. And of course, if maybe has 51 years old, but has +4 of hyperopia, maybe at that time, I will make it intraocular lens. But in some patients of that age, women mainly, I prefer to do LASIK for far, and with the ablation in the center, because of that, I use Vizx, can improve near vision a little bit, and I reinforce the surgery with my drops. So even though I didn't make any intraocular surgery in that 51, 52-year-old patient, so you can mix everything. So thank God I have my drops, so I can help the patients with that. So I can do LASIK, and if they need a little bit more for near, because I programming for far, I can help them and reinforce with the drops.
Yes, Dr. Alio,
Yeah, let me tell you. Now, what about if you have a minus 1.5 patient? This patient is now minus 1.5 and is plus 1.5 to read, you know? Obviously, this patient removing the glasses to read, but for far cannot drive without glasses. So what is your option? I know that Dan is for corneal presby LASIK procedures. I'm sure that Felipe is as well. What is the opinion of Federico Alonso? Federico, what do you do in this minus 1.5 guy?
In my opinion, I think in patients with crystalline transparent, lens transparent, and with low and moderate presbyopia, is presbyon, but it's necessary 2-3 keys. The first, the centration. The most important is not change the kappa angle. The kappa angle not change, because in the future of the cataract surgery is a problem. The second, especially in moderate presbyopia, the change of the keratometry and thin epithelium. This is a problem for cataract surgery and for visual quality in change of keratometry, especially in moderate presbyopia, in presbyon, the epithelium. That thick epithelium, is a problem.
How is it a problem? We haven't.
Julio, what would you do in this minus 1.5 guy? Julio Ortega.
For sure, I would do LASIK or PRK in just the dominant eye. That's what I would do. And so, listen. The debate here is for sure. I totally agree with my colleagues. If we compare the risk with corneal surgery and with intraocular surgery, no way. For sure, there's more risk with the intraocular surgery. So there's no debate about that. I totally agree with them. But I mean, in the hyperopes, it's the same thing as in myopes. So in your patient, Professor Alio, with a minus 1.5 in both eyes with a presbyopia 1.5 is just operate on one eye. That's it. LASIK or PRK. But I don't perform presbyon. For sure, it's because I don't have experience with presbyon. I have experience with classic monovision. With classic monovision in my hands, patients afterwards, I've been operating patients for more than 20 years. So now the patients come to me with LASIK and I perform trifocal IOLs. What if 24 years ago I had performed presbyon? I don't know. You know why? Because there is no evidence. So we don't know. So what about risk? That's risk. Performing an corneal ablation with a special optics. We don't know in the future. Let's see.
Julio, it's not special optics. It's controlled spherical aberration. It's not like Presbymax where there's a central island. It's not like a Bausch & Lomb supracore. It's not a multifocal cornea. You have to separate presbyon from all of the other corneal solutions. It's a different class. I agree with you. If you have a multifocal cornea, this is not a great situation. In fact, we've completed a literature review until a month ago for the ESCRS. Complete literature review. There still is not the possibility of performing multifocal corneas without loss of 2 lines of best spectacle corrected vision at unacceptable levels. Presbyon is not doing that. So you will feel much more comfortable when one of my patients moves to Spain to retire and they get a cataract and then 68 years old, you just use an IOL Master 700, you put the Barrett True K on, you do your calculations, you put a monofocal in, they're going to be so happy. It's not an experiment. It's absolutely logical. putting multifocals in, that complicates the situation because now you're dividing the light which doesn't require to be divided because the depth of field is already in the cornea. That's all I'm saying. You must consider that if the aberrations of the cornea already provide the depth of field, then you don't need to add division of light on top of that. It's not necessary.
I would like
and
to
the PCO
add some,
rates.
Dear colleagues, I would like to share some information that is evidence-based and scientifically proven, which is actually a patient who has an axial length over 23 millimeters and under the age of 60 years old is a very high increased risk of retinal detachment. So in my way of approaching patients, I always look at age and axial length. And if the patient has an axial length exceeding 23 millimeters and has no cataract and is under 60, I never perform an intraocular lens exchange. That's something that adds some important piece of information, to share in this round table. On the other hand, I also think that patients, particularly women, around 50, they are very much prone to severe dry disease, particularly if they receive a LASIK. And I would like to ask for your experience about receiving LASIK in a patient who is hyperopic, particularly women that that are undergoing, some hormonal changes. What is your experience? Do you get many of these LASIK-induced neurotrophic corneas, Jan Racing?
Wait a minute, neurotrophic? You mean chronic pain?
Chronic pain and chronic ocular surface alterations in these patients.
Okay.
Do you see them often in your?
Yeah, the chronic pain is a 1 in 10,000 problem. It's very, very rare. But what you're talking about, I think, what you're asking me about is exacerbation of meibomian gland dysfunction and exacerbation of immune-modulated dry eye. So accessory glands where you put fluorescein in and you see staining on the conjunctiva. And you're absolutely right that when the hormonal situation drops in women, they get this kind of inflammatory background ocular surface. And this has to be optimized. It has to be optimized either by conventional measures, meibomian gland dysfunction management measures, or by a topical cyclosporin. But I would argue that you really should be doing this anyway if you're going to do a lens surgery, because especially if you're going to use a multifocal, because the quality of the tear film really impacts the optics of multifocals. And so these women with depressed hormonal function and rapid breakup time and poor meibomian gland dysfunction and conjunctival staining, they shouldn't be having any surgery until their ocular surface is optimized. Now, in our experience, so about 35% of the 10,000 patients that we've treated with Presbion have been hyperopes, okay? And 60% are women. So you can calculate that. We spend a lot of time, maybe months, optimizing the ocular surface before we do any surgery, even if we're going to do lens surgery. But when you optimize the ocular surface before starting, then the drop that you're going to get because of the LASIK or intraocular procedure starts from higher up. If you're starting down here and then you get a drop, it can be quite a severe ride. Whereas if you push the ocular surface to the top and then get the dip, it recovers and you get the sort of normal post-LASIK, tear film instability. We don't find it to be a particularly problematic issue. That's all I can say. I think that there is a lot of folklore about not being able to do LASIK in people over the age of 50. But that has not been our experience in the last 20 years.
Okay, gentlemen, thank you, because we are time off. And this debate really puts everything on the stage. We don't have an adequate agreement based on evidence. And this is very emotional, you know. The tradition, our culture, our education, and the environment in which we were pushes us in one or another direction. I think, personally, that the cornea is safer surgery than intraocular, even that I am intraocular surgeon as well. But I think that this debate is open, will be open for the next year, and definitely this type of discussions, it might be not tremendously positive for those that are our audience at this moment, because they will have more clear which are the options and basically which are the positions, because we have different positions but not that much based on evidence. I do agree with everything that has been mentioned. I think that Julio represents well the intraocular lens defenders, you know, while Dan is for the cornea. Personally, I'm in between. Federico is more in the cornea, and Felipe is in between, but with some hidden card, you know, which is the drops. Drops work well. Let me tell you that we are not fortunate not to have the drops already available, because I get the drops from him. He's kind enough to supply them to us. And the drops helps a lot early presbyopes and helps a lot those that have had already all the types of refractive surgery in clearing the near vision in older ages. So I want to thank everybody. I want to thank Miguel Maldonado to be here with us, and I think that this discussion is open for the next year. Thank you very much indeed. Thank you.
Thank you so much. Thank you. Thank you.
Thank you. Okay.
Lens surgery, when reported, please report it according to the standard graphs for reporting refractive surgery. Please report the cumulative vision, and please report in clear lens exchange the loss of 1 or 2 or 3 lines of best spectacle corrected vision. Because this is, if you look at the lens publications, 95% of the publications do not have that data. And so the way that lens surgeons are interpreting lens surgery is not equivalent. And I just say that when you do that, you find how inaccurate IOL vision is compared to corneal surgery. And you also find that in clear lens exchange, I was shown very nicely by Joaquin Fernandez, is that 2 to 3% of eyes lose 2 lines of best spectacle corrected vision in clear lens exchange in hyperopes. So there's a lot of misconception about the safety of IOL surgery, and that is driven commercially, of course, and by local rules and local necessity. And I agree, Jorge, that is not wrong to do one thing or the other. But if we're discussing things in terms of objective parameters, we need to be objective. And I'm sorry, but the lens community has not been responsible enough to do this in a way which is comparable. And that's the only comment that I would make to the lens exchange community in the clear lens exchange world.
Okay, so thank you very much, and we close the session, but we shall continue. Thank you very much, everybody.
Nos estresa que la lente se pueda voltear.
Un paso importante, o sea, es una lente muy buena.
Y esto no va a pasar con la lente iCream.
Y especialmente tamaños de 13. Nos van a hacer que, bueno, que tengamos un control.
El material de la lente OptiFlex es un material muy resistente a la formación de microvacuolas.
And this may be the best hydrophobic in lenses I've never implanted.
Y con una rapidez de resultados bastante impresionante.
Es una de las escasísimas lentes con las que me siento cómodo.
Confirman una respuesta excelente a todas las distancias.
De una manera mucho más agradable, mucho más vistosa y con menos posibilidad de que podamos encontrar algún volteo a la hora de poner la lente en cámara anterior.
O sea, quirúrgicamente se comporta de forma excelente y el aspecto de la lente es excelente.
Los estudios de laboratorio sugieren una gran seguridad